Hi, today we will be discussing Chapter 28 of Harrison's Principles of Internal Medicine. This chapter deals with disorders of the eye. This slide set is part 1 of 2 on eye disorders causing chronic visual loss in this chapter. In this set of slides, we will discuss 3 etiologies, namely cataract, glaucoma, and macular degeneration. Cataract is a clouding of the lens sufficient to reduce vision. Most cataracts develop slowly as a result of aging, leading to gradual impairment of vision. The formation of cataract occurs more rapidly in patients with a history of uveitis, diabetes mellitus, ocular trauma, or vitrectomy, but may also be acquired in a number of genetic diseases. Radiation therapy and glucocorticoid treatment can induce cataract as a side effect, and they are usually posterior subcapsular in location. Cataract can be detected by noting an impaired red reflex when viewing light reflected from the fundus with an ophthalmoscope or by examining the dilated eye with the slit lamp. The only treatment for cataract is surgical extraction of the opacified lens. Glaucoma is a slowly progressive, insidious optic neuropathy that usually is associated with chronic elevation of intraocular pressure. After cataract, it is the most common cause of blindness in the world. The mechanism by which raised intraocular pressure injures the optic nerve is not understood. Axons entering the inferotemporal and superotemporal aspects of the optic disc are damaged, first, producing typical nerve fiber bundle or arcuate scotomas on perimetric testing. As fibers are destroyed, the neural rim of the optic disc shrinks, and the physiologic cup within the optic disc enlarges. Observation of progressive cupping and detection of an arcuate scotoma or a nasal step on computerized visual field testing is sufficient to establish the diagnosis of glaucoma. OCT reveals corresponding loss of fibers along the arcuate pathways in the nerve fiber layer. The preponderance of patients with glaucoma have open anterior chamber angles. Surprisingly, a third of patients with open-angle glaucoma have an intraocular pressure within the normal range of 10 to 20 millimeters mercury. For this so-called normal or low-tension form of glaucoma, high myopia is a risk factor. Chronic angle closure glaucoma and chronic open-angle glaucoma are usually asymptomatic. Only acute angle closure glaucoma causes a red or painful eye from abrupt elevation of intraocular pressure. In all forms of glaucoma, foveal acuity is spared until end-stage disease is reached. For these reasons, severe and irreversible damage can occur before either the patient or the physician recognizes the diagnosis. Screening of patients for glaucoma by noting the cup-to-disc ratio and ophthalmoscopy and by measuring intraocular pressure is vital. The following are the treatment options for glaucoma. Macular degeneration is a major cause of gradual, painless, bilateral, central visual loss in the elderly. It occurs in a non-exudative dry form and an exudative wet form. The non-exudative process begins with the accumulation of extracellular deposits called drusen underneath the retinal pigment epithelium. On ophthalmoscopy, they are pleomorphic but generally appear as small, discrete yellow lesions clustered in the macula. With time, they become larger, more numerous, and confluent. The retinal pigment epithelium becomes focally detached and atrophic, causing visual loss by interfering with photoreceptor function. Treatment with vitamins C and E, beta carotene, and zinc may retard dry macular degeneration. Exudative macular degeneration, which develops in only a minority of patients, occurs when neovascular vessels from the choroid grow through defects in Bruch's membrane and proliferate underneath the retinal pigment epithelium or the retina. Leakage from these vessels produce elevation of the retina with distortion and blurring of vision. Fluorescein angiography and OCT are extremely useful for their detection. A major therapeutic advance has occurred with the discovery that exudative macular degeneration can be treated with intraocular injection of antagonists to vascular endothelial growth factor. This ends part 1 of the slide set for chronic visual loss. Next set of slides will be part 2, where another 5 disorders of the eye that cause chronic visual loss will be discussed.